Thank you very much. I think Salam Alaikum, it's correct. So nice to meet you again. My topic is about glycemic management in high cardiovascular risk. It was opened a gate by the previous speaker, which I congratulate for the presentation. And seems that we have the same problem with hypertension and diabetes to find the best values to protect the patients from cardiovascular diseases. So, unfortunately, the life expectancy is reduced by 12 years in patients with diabetes compared with the persons free of diabetes, stroke, or myocardial infarction. So, as you see, at the age of 60, unfortunately, the life lost is much higher than in persons without diabetes. There are a lot of mechanisms by which diabetes leads to coronary heart disease. And this is what we know. We know about infection, which decreases the defense mechanism. We know about inflammation, and we have some important biomarkers showing us that these will impact the endothelial function. And of course, hyperglycemia, which increase the oxidative stress and advance glycemic end products. On the other hand, we have insulin resistance, which is present in almost all patients with type 2 diabetes, also impacting the endothelial dysfunction. Dyslipidemia, and you know that it is characteristic for type 2 diabetes, characterized by increase of LDL cholesterol, increase of triglyceride, and decrease of HDL cholesterol. And we all know that it's very difficult to target the level of 55 milligrams for LDL cholesterol, which is the new target in patients with diabetes and cardiovascular disease. But it is also very difficult to increase the HDL cholesterol. And it is a joke about a man speaking with his friend. He was stopped on the road by a policeman, and they have a quarrel concerning red wine. The driver said that red wine is good for circulation, and the policeman said no. And going further, we know that they are very exposed to thrombosis in patients with diabetes. So these all will lead to subclinical atherosclerosis. And with disease progression, atherosclerotic will have clinical events. So what are the most important cardiovascular diseases in diabetes? Of course, the first one, cardiovascular death. And we know that this is the leading cause of morbidity and mortality in diabetes patients. And seems that the risk for cardiac artery disease is threefold higher in type 2 diabetes, and up to 80% of mortality in type 2 diabetes patient is due to cardiovascular diseases. Type 1 and type 2 diabetes subject with no previous myocardial infarction are at a similar risk of an acute coronary event as persons without diabetes but with established cardiovascular disease. And this is a study from myocardial infarction registry in Finland, and they show here 1 year mortality rates after myocardial infarction. And as we see, the highest risk for mortality have the patients with diabetes and prior myocardial infarction. Of course, when we speak about acute myocardial infarction, you see that in the last year, the incidence of myocardial infarction decreased with 32% in persons with or without diabetes. But if we look at the population with diabetes, we see a 67% decrease in events from 1990 till 2010, and this means that if we control cardiovascular disease and diabetes, we can improve the life of patients with diabetes. And as you see, my previous colleague said about association of diabetes and hypertension. Of course, this increases the risk of myocardial infarction, regardless of prior myocardial infarction status. Heart failure become more and more important and now is in our attention. And we have arguments for this. Unfortunately, heart failure is one of the first manifestation of type 2 diabetes and related cardiovascular disease. And if you see, is the second in the percentage of the events as first cardiovascular disease. Type 2 diabetes trials show that heart failure prevalence is high. Some of them said 10%, some of them 30%, but what is important is that sometimes heart failure and type 2 diabetes coexist. Of course, we know from the clinical trials that type 2 diabetes increase also the risk of development of heart failures symptoms and also heart failure hospitalization. Unfortunately, we know that a patient with heart failure and diabetes at the moment of diagnosis has a shorter life, at least 5 years after diagnosis. What about stroke? Of course, again, we have to look at the clinical trials showing that population with or without diabetes has the same incidence or prevalence of stroke starting from 1990 till 2010. But if we look in the population with diabetes, we see that it is a decrease of 52% in events in the same period of time. Meaning again that if we prevent cardiovascular disease, the stroke will not be so frequent. TNT study showed that in spite of treatment with high doses of statin in patients with diabetes, still exists a residual risk for cardiovascular disease. They still experience events even with therapy, and it doesn't matter if the dose of statin is high or low. On the other hand, STENO-2 study, which was an intensive multifactorial therapy, showed that patients still experience events. In the intensive treatment group, survival was improved by 7.9 years, but death from cardiovascular disease was reduced with 62%. If we look to our important old studies in diabetes, like UKPDS, VADT, ADVANCE, we will see that in spite of controlling diabetes, they don't succeed in controlling cardiovascular events, except with UKPDS, but please look at the follow-up period, it was 17 years. So maybe we have to expect to protect patients with diabetes from cardiovascular events only if they have a very good metabolic control, if we target the blood pressure and the lipids, but still we are not very successful in this field. If we speak about cardiovascular risk assessment in patients with diabetes and pre-diabetes, we have to look at the European guideline, which was elaborated in 2016. And we will see that there were three important categories: low to moderate risk person. At this group we should be offered only lifestyle advice to maintain their low or moderate risk. High risk persons, where the quality for intensive life advice and were not enough, and these are candidates for drug treatment. And we have very high risk persons where drug treatment is very necessary. But if we look what happened in 2019 with the European Society Cardiology guideline, we see that this group of risk changed, and we have very high risk patients. This means patients with diabetes and established cardiovascular disease, or target organ damage, or three or more major risk factors, or early onset of type 1 diabetes of long duration, more than 20 years. Then we have high risk, meaning patients with diabetes duration more than 10 years without organ damage or other additional risk factors. And we have moderate risk, and we have to admit there are very few patients in this category. Young patients with type 1 diabetes, age less than 35, or type 2 diabetes less than 50, with diabetes duration less than 10 years without other risk factor. And it's important to look at this risk factor because concerning this new category of risk factor, we have to choose the treatment, appropriate treatment for persons with diabetes. And as I explained in my first topic, in patients with diabetes and established atherosclerotic cardiovascular diseases, we have to choose a GLP-1 receptor analog because they have proven cardiovascular benefit, or we have to choose CGLT2 inhibitors, also with proven cardiovascular benefit. The order to choose is liraglutide because it has the strongest evidence, semaglutide where the evidence are favorable, and exenatide where the proven is less certain. Concerning the CGLT2 inhibitors, empagliflozin and canagliflozin, they have strong evidence concerning cardiovascular protection. Treatment for patients with cardiac failure or chronic kidney disease is not at our option, but the guideline gives us the steps to follow after metformin. And the recommendation is for patients with heart failure and chronic kidney disease, preferably the CGLT2 inhibitors, and if they are not an option, then we can choose the GLP-1 receptor agonist with proven benefits. Of course, we have to be focused also on hemoglobin A1C and make the changes as soon as possible, not the patient to remain out of the target of hemoglobin A1C. In 2090, European Society of Cardiology give that guideline on diabetes, prediabetes and cardiovascular disease with a focus on glucose lowering treatment. It's the first time when our colleagues from cardiology look so close to the target of glucose. This is the first guideline to recommend the CGLT2 inhibitors or GLP-1 receptor agonists prior to metformin in patients with established atherosclerotic cardiovascular disease. And this guideline move beyond the treatment of patients with diabetes because they were focused on cardiovascular risk and the current evidence with the new therapy. Treatment algorithm, as you see, have the priority, the established of cardiovascular risk category, very high risk or moderate risk, because concerning the class of risk, we have to choose the treatment. But what this algorithm shows us is that also CGLT2 inhibitors or GLP-1 receptor agonists are recommended in patients with type 2 diabetes and cardiovascular disease. And what these guidelines said that in patients drug naive with type 2 diabetes, the first choice, if they have atherosclerotic cardiovascular disease, is the CGLT2 inhibitor or GLP-1 receptor analogs. And if the hemoglobin A1C is above target, then we can add metformin. In patients without atherosclerotic cardiovascular disease, metformin remains the first choice, and then we can add what we consider concerning the patient in front of us. CGLT2 inhibitors or GLP-1 receptor agonists are recommended in drug-naive patients with high cardiovascular risk as the first line of therapy. And if we address a patient having metformin, then we have to add one of the two classes, and we have to be focused on hemoglobin A1C. But what is important is that these two drugs are recommended in patients on metformin with atherosclerotic cardiovascular disease, irrespective of hemoglobin A1C. This means that in these persons having metformin on treatment, even if they have or not the hemoglobin A1C in target, if they have cardiovascular disease, they can benefit from the association of one of these two classes. When we consider to use CGLT2 first, when patient and clinician include this priority, reducing MACE and cardiovascular death, preventing heart failure hospitalization, reducing blood pressure, but of course this is not a drug for hypertension, and it is well accepted by the patient because it's orally administered. When we consider GLP-1 receptor analogs, when we want to reduce MACE and cardiovascular death, when we want to reduce weight, when the therapy, when EGFR is below 45 milliliter per minute and 1.73 square meters, and Again, it's well accepted by the patient, being injectable but being administered once weekly. There are a lot of potential effects by which SGLT2 inhibitor improves heart failure, starting from reduce preload and afterload, improving myocardial energetics and cardiac remodulation. And this will have clinical effects like blood pressure reduction and improve cardiac contractility. And these all give a protection against myocardial injury and heart failure. So the recommendation is liraglutide, semaglutide or dulaglutide and in patients with established cardiovascular disease, and as you see is class 1A recommendation. And liraglutide is recommended in patients with type 2 diabetes to reduce the risk of death. And we have the clinical trials that showed this: LEADER, SUSTAIN and REWIND, and as you see, LEADER and SUSTAIN had very important effect on patient events. Also, GLP-1 has a lot of potential effects on cardiovascular system, going to effect on the pancreas, increasing insulin secretion, glucagon secretion, going to the liver, decrease glucose output, then effects on the brain, decrease appetite and increase neuroprotection, and of course muscle and adipose tissue where improve insulin sensitivity. And all these have a very important and protective effect on the heart. So if we look to the guidelines, we have to choose the treatment concerning some very important things. Management of type 2 diabetes is becoming increasingly complex because there are therapies providing benefits beyond glucose lowering, which are now available. And of course, in patients with diabetes, we are not interested only in hemoglobin A1C, but also in blood pressure and lipid profile. The use of this comprehensive cardiovascular risk management and patient-centered care strategy are critical to reduce complication and, of course, to maintain the quality of life. With regards to the management of medication for patients with clinical cardiovascular disease, SGLT2 inhibitor or a GLP-1 receptor agonist with proven cardiovascular benefits is recommended. So if we are facing in the right direction, all we have to do is keep on walking. Thank you very much for your attention.